Thank you so much for that very kind introduction. And I feel super honored to follow such prestigious speakers. And I'm really excited to talk with you all about early mobility. My only disclosure is that I do receive NIH funding through an internal KL2 program. I want to start off with the fact that you all are doing an amazing job when it comes to neonatal mortality. Neonatal mortality has been steadily declining over time. This is data from national data from the US. And in particular, you all are doing a very great job when it comes to children of younger gestational ages. In every gestational category, mortality has steadily been declining. However, what we have work to do, both in the pediatric intensive care space and the neonatal intensive care space, is when it comes to NICU graduate disability. When you look at children with special healthcare needs graduating from the NICU, you have a rate between 20 to 80% of children needing special healthcare needs. When you look at neurodevelopmental outcomes, you have a rate between 5 and 70% of children having neurodevelopmental disability. And when you look at special educational needs, children have between 15 and 75% disabilities leaving the neonatal intensive care space. And when you look at behavioral disabilities, this data is newly emerging, but between 5 and 20% of children leaving the NICU will have behavioral disabilities. So why am I talking to you about this? I'm a PICU doctor, but what I'll tell you is that there is a decent amount of overlap between our patient populations. PICU patients are increasingly becoming younger in age. 28% of our patients are actually infants at this time, and greater than 60% of my patients are less than 2 years of age. Meanwhile, your patients are actually getting a bit older. About 80% of your patients are greater than or equal to 34 weeks gestational age, and your length of stay is increasing over time. So you have children that are staying in your neonatal intensive care space on average, it seems about 4 to 8 weeks. And so therefore, our patient population overlaps quite a bit. And as I said to you, my problems are pretty similar to your problems. My mortality rates are also decreasing. You can see in the light blue bar from the 1980s to now, our mortality rate has declined from about 20% to under 5%, while my disability rate has increased steadily. Currently, children leaving the PICU have a disability rate of about 20%. So what I'm here to propose to all of you is that the goalpost is really moved. We can no longer use mortality as a marker of success. We really have to look at our morbidity rates as markers of success. So as many of the speakers have already talked with you about, early childhood is a developmentally vulnerable period. And what we have here is a patient that we could see in either of our spaces, a child that's heavily sedated, a child that's intubated, in a non-developmentally appropriate position without parents at the bedside, and a really wonderful scoping review about neonates' experiences in the neonatal intensive care space showed that in general, the NICU is too loud, too painful, that parents only hold their children less than 3 days a week, that it's too bright, and that both parents and providers describe the space as traumatic. So what I study is something called ICU liberation. And what ICU liberation is it's a bundle of care that we refer to as A, B, C, D, E, F. A being assessing and preventing pain, B being spontaneous breathing trials, C being choice of sedation, D being delirium monitoring and management, E being early mobility and exercise, and F being family engagement. And what I would say is you all are doing this already when you do developmentally appropriate care. You have protected sleep, you have pain and stress assessment and management, you have developmentally supportive activities of daily living and family-centered care, and the healing environment. And what I'd like to focus on specifically is early mobility and family engagement with you today. And why this is important is, unlike adults, for children, our focus is not rehabilitation. We are not worried, well, we are worried about children losing skills, but really our children are in our space during a critical period of skill attainment. And so our focus should be making sure that they're attaining the skills that we need them to attain while they're with us. So what is early mobility? By my definition, early mobility is age and developmentally appropriate physical rehabilitation within 72 hours of hospitalization. And what I would argue for you all is that really kangaroo care is early mobility. And there are many, many benefits, which I think you all know very, very well. There's increased cardiorespiratory stability, there's improved thermoregulation, there's improved weight gain, there's improved cerebral oxygenation, there's improved sleep, there's decreased response to pain, and decreased risk of infection from performing kangaroo care. And what you see here on the slide on the left is actually a systematic review looking at long-term neurodisability in children that have received kangaroo care, and overall, it's protective for neurodevelopmental disability. So at this point, I say, great, let's move all our kids. Why are we not? And sorry, I don't have a lot of pictures of babies. I only have PICU patients. And really, who we're asking to do the heavy lifting of early mobility and kangaroo care are our nursing colleagues. Kangaroo care is exclusively a nursing intervention. And in the PICU, nurses mobilize greater than 65% of all of our PICU patients. And in fact, physical therapists only mobilize about 30% of our PICU patients. However, nurses, even the nurses that are moving patients, perceive a variety of barriers to early mobility. Those barriers include insufficient training, lack of guidelines and protocols, and safety concerns. And when our nurses are concerned, it comes out in the results that we see for our patients. Nurses are particularly concerned about mobilizing younger and mechanically ventilated patients, and as such, we know that younger and mechanically ventilated patients are mobilized less often. And nurses who are familiar with early mobility protocols assess our patients at higher mobility capacity. So let's look one at a time at the concerns that our nurses have. First, our nurses are concerned about lack of guidelines and protocols, and they're concerned about inconsistent guidelines and protocols. So at Johns Hopkins, in 2013, we did not have an early mobility protocol, and most of our patients were immobile on most days. We developed a structured interdisciplinary program and integrated it into the routine care of the child with a particular focus on sleep promotion and delirium prevention. After the program was implemented, we saw that our physical therapy sessions increased from 53% to 82% for our patients, and the median number of mobilization activities per patient day increased from 3 to 6, and that was the majority of those were led by nurses. We had 0 adverse events, and we were able to mobilize. We increased the number of children that were mobilized with an endotracheal tube from 0% to 10%. This is the PARC PICU study, which was a 2-day point prevalence study of about 1/3 of US PICUs. And what I'm showing you here is specifically that institutions that have an early mobility protocol were actually more likely to mobilize children. So let's look at mobility protocols in the neonatal intensive care space. And this was a realist review looking at what policies show us about kangaroo care in the neonatal intensive care unit. And the overwhelming result of this study was that there's a lot of inconsistencies in your policies. They don't follow national guidelines. The exclusion criteria are highly variable, and they are not in line with what the nurses are able to do themselves. When you look, there's no data that I was able to find that shows how common there's a kangaroo care policy within NICUs in the United States. This is data on early mobility policies within the pediatric intensive care space. Actually, this is all of the elements of the ABCDF ICU liberation bundle. But what you can see is that early mobility protocols were were the least likely component of the ICU liberation bundle to have a protocol within institutions in both the US, in the US, Canada, and Brazil, and Europe. Only 30% of US PICUs have an early mobility protocol. So first, we need to have protocols that are consistent and incorporate our nursing colleagues. Next, we need to address safety concerns. So this was my work looking at risk factors for safety events with mobility in critically ill children. This was a secondary analysis of the PARC PICU study. So we looked at 1,433 patient days and 4,658 mobility events, and we found a 4% safety event rate when we were mobilizing our critically ill children. That was 194 safety events. The far majority of those safety events were transient physiologic changes, so 3% of all events had a transient physiologic change. Only 0.3% of all events had dislodgement of medical equipment, and there was no cardiac arrests or falls. After conducting univariate analysis, we conducted a multi-level logistic regression model to determine risk factors for mobility, and we found that there was no PICU intervention that was associated with an increased risk of safety events when mobilizing critically ill children. Slightly less relevant to you all, but delirium was the single biggest risk factor for having a safety event while mobilizing critically ill children. Since transient physiologic changes were the most common safety event that we all had, I looked at transient physiologic changes that you have in your neonatal intensive care space. And I think you all know this, but kangaroo care is actually associated with a better physiologic profile than not being mobilized. So therefore, here you see in 30 neonates that their heart rates were improved when they were held by a parent, and that their respiratory rates were also improved while they were held by a parent. I think the thing that scares all of us when we mobilize a critically ill infant is unplanned extubations. And really in your space, there's mixed evidence on unplanned extubations. Some studies have shown that there are increased unplanned extubations when mobilizing neonates, and some studies have shown that there is not. But what I have here is a quality improvement project that was done out in Cincinnati. And what they showed is that with education, they were able to decrease the rate of unplanned extubations associated with kangaroo care while increasing kangaroo care. So really, this brings me to my last point, which is lack of education. So simulation has been broadly utilized in medical education and has been known to improve outcomes. However, there's only 4 descriptive studies looking at ICU rehabilitation in the simulation space. One study done in a neonatal intensive care unit showed that utilizing a simulation curriculum for our nurses increased the number of infants receiving nurse-assisted parental holding from 26% to 85%, and that represents a 224% increase in parental holding. There is a decreased time to first parental hold from 18 days to 5 days, and there was an increased mean duration in parental holding from 73 minutes to 203 minutes. So educating our nurses is the most important thing we could do to get our infants mobilized. And in fact, our nurses want education on mobility. This was a sustainability analysis of our Pick You Up program. And what we found was that our nurses wanted mobility education and reported that it would improve their confidence and increase competencies with appropriate mobility activities and emergency plan development. So my objectives was to design and implement a nurse-targeted, simulation-based early mobility curriculum to see if it improves nursing self-efficacy, knowledge, and skills. First, we conducted a targeted needs assessment, which found that globally, our nurses were wildly underutilizing our existing protocol. And when we asked them for what they wanted to learn about, our nurses cited that they wanted to learn about patient body mechanics, nursing ergonomics, lift devices, how to mobilize larger infants, and how to arrange a room and secure equipment appropriately. Together with a large interprofessional team, we developed the following curriculum objectives for our simulation. Overall, these objectives were in line with our Pick You Up protocol. We then designed a simulation day, and the simulation day consisted of pre-intervention knowledge assessment, self-efficacy assessment, and clinical skills assessment. Then the nurses participated in 2 educational simulations and didactics, and then they repeated all of the assessments post-intervention to determine if there was an effect. The simulation that we did that we assessed our nurses' clinical skills was a 14-month-old X-24-week infant with chronic lung disease, trach vent dependent at baseline, who came in with RSV, and we asked our nurses to mobilize this mannequin from a bed to a chair. The second simulation that we conducted was a 1-month-old X-full-term infant who had severe left-sided congenital diaphragmatic hernia, status post an ECMO run, and a CDH repair, who had continued respiratory failure. And the goal of this simulation was to move the mannequin from a bed into a standardized patient's arms who was playing the patient's parents. And then less relevant to you all, our last simulation was an 18-year-old who had pneumonia in a chest tube. One of the things that our nurses identified as a barrier to mobility was actually our room design. And I think this is a problem that you all have too with the small spaces. And so we mocked up our simulation lab to be identical to our space. And that includes the measurements and all of the equipment in the room. This here is a video of, is a video of one of our simulations. What you could see is that there are 3 nurses mobilizing our mannequin into a standardized patient's arms. That's the gentleman in red. There's also a woman in the back playing an embedded actor as a respiratory therapist. Each nurse got to participate in the simulation individually as the leader, and then they received real-time feedback and didactics during the simulation. We know that 80% of all mobility time is spent arranging lines and tubes. So this is actually about halfway through the simulation, during which the nurses had spent the majority of the time arranging lines and tubes. In terms of results for our study, this was a pre-post interventional study. Our nurses had a median of 2 years experience, and this is actually what our nursing population and in our entire intensive care space has in terms of experience. We found that we had a significant improvement in nursing self-efficacy post-intervention. We found that our nurses had improved knowledge post-intervention, and we found that our nurses had improved clinical skills post-intervention. We asked our nurses for written feedback, and overall they described the simulations as positive. They said that they would want to participate in the simulations again. In terms of strength, they said that the standardized patients, the embedded actors, and the fidelity to the PICU room were the strengths. And in terms of weakness, they felt like some of the cases were a little too easy. Obviously, our study isn't without limitations. We had a small sample size, we have lack of longitudinal data, and we have a lack of information on impact at the bedside. But we did demonstrate that we could design a nurse-targeted simulation-based early mobility curriculum based on educational theory, and that the curriculum improved nursing mobility, self-efficacy, knowledge, and clinical skills, and that the curriculum was well-received and desired in the future. We are planning on implementing this curriculum in situ within our unit to determine if it increases the number of nursing-led mobility events and the highest level of mobility achieved by our nurses, and then we're planning on expanding this curriculum to our entire interprofessional team. So thank you so much for your time. In terms of my summaries, as mortality improves, it's really our job to focus on functional outcomes for our critically ill children. Early childhood is a uniquely developmentally vulnerable time, and the ICU space itself is a threat to that development. Early mobility can improve outcomes and is safe. Early mobility is a team sport that relies heavily on our nursing colleagues, and an early mobility protocol that's consistent and within line with our nurses' goals is a key to success, and simulation is one opportunity to help them. I have lots of people to thank, but mostly I really appreciate all of your time. Thanks so much.